What do we understand about the percentage of people that become critically ill? Do we have that data? How much does it actually impact us?
Yes. So we know that when we're looking at how many people become critically ill, we're still looking at approximately 20% of people hospitalized, needing some form of acute care. And of that group, approximately half will need some form of mechanical ventilation. Now, those needing mechanical ventilation tend to skew toward our older population, and we're still seeing that data in the United States consistent with what we've seen around the world.
Does our response team in the US and in other parts of the world have enough equipment, have enough personal protection to deal with the virus in the coming weeks and months?
So the administration has finally started to offer support to the states in trying to get more PPE. There have been Herculean efforts by various governors across the United States to bring in more N95 masks, to bring in more gowns and gloves, to bring in face shields for our frontline healthcare workers. That has been different across states, and as you've seen reporting, different governors across the United States have had to basically barter, beg, and steal, for lack of a better word, personal protective equipment from various agencies, including going overseas to obtain, masks from China and their support, masks from other countries. It's also, in my home state of Maryland, the governor has launched a N95 reprocessing center, one of the largest in the country, to facilitate the reuse and cleaning of N95 masks, which is something that's unheard of. We would never typically reuse those types of masks. So we're being very resilient in our efforts to try to make sure we have enough PPE.
Dr. Farley, you are expert in the epidemiology of infectious diseases, and your Johns Hopkins has flat out done the best job of a regional, a city, almost a nationwide epidemiology and study of these statistics. The statistics, the slopes, the second derivatives for some of these regions, California, Florida, they're really not very good. New Jersey, it's not happening. Tell us about the diffusement of a virus from hot spots, which get all the media attention, out into the greater public. What is the experience you have of infectious disease from hot spots out to broader geographies?
Sure. So when we talk about hot spots, it's important for everyone to understand that's where we have ongoing replication of the virus and transmission of the virus. When we know what the infectivity potential of the virus is, and that's what we call the R naught. In this case, it's between 2 and 3. And so that means for every person that you infect, a person with COVID infects, they're going to infect approximately 2 to 2.5 to 3 people with the virus. And so hotspots allow that propagation or that transmissibility to occur in an ongoing basis. Now, the trickle effect, bleeding out into other locales and locations. The perfect example in the United States right now is Rhode Island. It's been getting cases coming in from New York State as well as in from Connecticut, and it was not deemed a hot spot, but because of migration, because of contact, because of people's movement, it has now started to see bleed over.